surgical care, an APSA member survey. Our representative is Dr. Chen, UT Southwest. Dr. Chen.
Thank you, Dr. Murphy. Thank you to the North Texas ACS for the privilege to present our work today. So a significant proportion of surgical neonates we know are cared for in non-pediatric environments. This is an analysis that I did last year, and basically 40 to 45% of surgical neonates are treated in adult general hospitals that don't have generally pediatric care. So they have NICUs, neonatal intensive care units, but not pediatric care. We also know that surgical neonates are a high-risk population whose outcomes need to be optimized, and we know this from relatively recent NISQIP data, which shows that looking at abdominal surgery in neonates and in the pediatric population, the neonates have an 8 times higher mortality and an almost 3 times higher all-cause morbidity. Previous studies have also shown that pediatric surgical patients in general have better outcomes when treated at children's hospitals, and this has been demonstrated in the trauma population as well as pyloric stenosis, intussusception. The list sort of goes on. And we might postulate that this is because children's hospitals generally have more pediatric-specific resources, but these resources are very expensive. So one theory might be, one way to optimize pediatric surgical care or care for surgical neonates might be regionalization. Now, what exactly do I mean by that? So one definition of regionalization is center designation and verification of resources for relevant patients by specialty society or other authority. And we're all familiar with this from a trauma center perspective. So trauma centers are designated by the ACS or by state, and there's level 1, 2, 3, 4. And that's a regionalized way that we take care of trauma patients. And so if this were to be undertaken for surgical neonates, then it would be important to actually understand how pediatric surgeons currently feel about this. So our study had 2 specific aims. One was to understand pediatric surgeons' attitudes or opinions toward this concept of regionalization, and also to identify the resources that pediatric surgeons feel are necessary for optimal care of the surgical neonate. We did this via an anonymous electronic survey, SurveyMonkey, and we invited the membership of the American Pediatric Surgical Association, the members who practice in the US, so we didn't survey the European and Canadian members. And we collected anonymously their demographic information as well as information on their clinical practice. In order to figure out what their attitudes were, we came up with a 15 survey item scale, if you will, so 15 questions on a survey, where lower scores favor regionalization. And I'll remind you of this as we go through it, because that's important in the interpretation of the results. And then in terms of optimal resources, there were 5 questions on those, and again, a lower score favored having those resources. And we also gave the surgeons a list of surgical and medical subspecialties, and we said, which of these do you feel are important to have in your hospital in order to care optimally for a surgical neonate? So the invitation went out to 916 pediatric surgeons, of whom about 40% started and completed the survey, which is actually reasonably good considering surgeons and surveys that come through email. This graph here shows the year that their training was completed. So 2012 over here, 1956 over here. And so you see the vast majority finished their training in 30 or 40 years ago. In other words, we had a pretty big span of people in practice that responded to the survey, which was good. We felt this was representative of our membership. The other question that we asked were how many people are in your practice group? And you'll see about half of them come from groups of 4 or less, half of them groups of 5 or more, all the way up to more than 20. What's important in this graph is that there weren't that many that came from more than 20. So the giant groups are not overly represented in this sample, and that again is important when looking at the results. So everyone knows pediatric surgery is generally concentrated in academic centers, and so we said, are you affiliated with a pediatric surgery training program and a general surgery training program? And 40% of our respondents actually worked with pediatric surgery fellows, and almost 90% worked with general surgery residents. One of the first questions we asked was for the respondent to respond to the question or the statement, I am in favor of formal regionalization, and about 2/3 agreed. This is the distribution. And however, when we broke this down, we found that those who were affiliated with a training program had a lower score, meaning they favored regionalization more than those without a training program, or who did not work with a training program. Now this, moving on to the 15 survey item scale here. So the possible score range goes from 15 to 75. Again, lower means favor regionalization more. And the overall mean score for the whole group was 42.8, which is just slightly to the favor side of neutral. So we broke it down by academic, non-academic, and those with a pediatric surgery fellowship favored regionalization more. Those with, those with a general surgery program also favored regionalization more. Not surprising. Moving on to the 5-question optimal resources scale. Possible range of scores 5 to 25. And again, lower is favoring having these resources listed here. Overall mean score was about 9. And so this is a little bit of a self-fulfilling prophecy, but pediatric surgeons feel that you need pediatric surgeons to take care of surgical neonates. But importantly, they also felt that you needed pediatric anesthesiologists and radiologists, and many also favored having a neonatologist in-house. When asked if a surgeon should cover more than one NICU on call or should stick with one, a little bit ambiguous, but just slightly, again, to the favor side of neutral. Looking at the total scores, those affiliated with a pediatric surgery training program favored having these resources more. And similarly with the general surgery training program surgeons, they favored these resources more as well. When asked to pick from a list of the pediatric surgical subspecialties that were necessary to have in-house with you when you're taking care of these babies, you see that a lot of people wanted neurosurgery there, and then those that were 50% or more were cardiac surgery, urology, and ENT, and understandably ortho, plastics, ophthalmology sort of were a little bit less popular, if you will. From a medical subspecialty standpoint, 90%, over 90% wanted cardiology there. And that's not surprising given the number of surgical neonates, pediatric surgical neonates, who also have congenital heart problems. But more than 50% of the respondents also wanted ID, GI, nephrology, pulmonary, hemo, and neurology with them. One other analysis we did was looking at group size. So does group size make a difference? And in fact, bigger group, the surgeons coming from bigger groups favored regionalization more on all of the 3 measures. So I am in favor of regionalization. They scored lower, meaning they favored regionalization more, as well as on the 15 survey question scale and on the 5 survey question scale. So in summary, overall, pediatric surgeons favored regionalization, but the groups that actually favored regionalization more were those affiliated with training programs and those who came from larger groups. And it's pretty intuitive, these are the surgeons who would benefit from regionalization. We also identified the subspecialty expertise that pediatric surgeons felt were necessary to optimally take care of a surgical neonate. And what this all adds to us is it helps us, it helps in the strategic development of implementation of policies if we were to get to that point to optimize care for surgical neonates. Thank you again for your attention, and I'm happy to take any questions.
The paper is now up for discussion.